Okay, so we go to our journal club. I want to go from our clinical practice, and as a matter of fact, we have been talking with my residents about biomarkers in Parkinson's and Alzheimer's. We have today actually one person that was one of our patients to have the biopsy in our group. So the resident had the opportunity to see the scars and again, we want to talk about that today. But again, I hope some of you shares picture. This picture that you see here is the moon you see there. So we look a little more about and still has some very nice flashback from coming from Venice. So we you will see some pictures there. So let's start.
How to get this full screen.
Somebody's speaking there. So this is for our class in Spanish, right? Es la clase en español. ¿Alguien me puede traducir qué dice ahí? Please translate. Somebody can tell me what they say there? Of the Spanish class? Sorry, say it again. Exactly. So this river passed through a road, a carreteras road. So this is just in Europe. It's amazing how they can actually direct a river after actually, like it's not, usually it's a bridge over a river. This is a bridge. They have actually the river in top. So, but this is the class for Spanish. So good for you, Richard. Ricardo, right? Ricky Ricardo. Very good. Rick, good for you. Again, Venice, I still have a good time there. Okay, and this is another moon right there. So yes, so this morning again, we had the opportunity to see one person with this skin biopsy. So what's important with the skin biopsy? Before we dismiss about the biopsy, but now we're talking about more the biomarkers. So I want to tell you again, this is a full video how to do it, but is these biomarkers is tell us a little more the approach of different uh, dopamine deficiency. And we're thinking it's only one protein, the alpha-synuclein, but it's in, the more we get, we know there is more proteins, and we get multiple proteins in that biopsy, we can actually say it exactly more the diagnosis. In the patient, so what? In the beginning, it's like you have a DAT scan. I said the DAT scan cannot distinguish between Parkinson's or Parkinsonism, but with the DAT scan, MRIs, and other biopsy, we can go to different diagnoses, different things that can look like Parkinson's. And we have a doctor in the house here, so I know two doctors. So basically, this is in the University of Toronto, and this is in the Journal of Movement Disorder, the International Movement Disorder Society. So they have a full video. You are interested for the doctors in house, they can do and click in this and look the full thing. And actually, is yes, I was watching last night and the video. It's a little bloody. It's a little bloody when you there. It could be a little scary, but they use like 3 millimeters or 4 millimeters biopsy, and they do in three places. One at the level of C7 in the thigh, and the other one in the ankle. And the difference between proximal and distal is very important from the alpha-synuclein. So actually, we were talking before. Dr. Hauser be here soon. I think the next month, if I'm not mistaken. And then we're talking just with Larry about this. So Dr. Hauser actually is one of the main names in movement disorder where we were honored to have him here. So for the next one, I will tell you before inviting somebody that's with Larry just told me. But and with him, we have a conversation because in the past, we're thinking about in the New England Journal of Medicine, there was a very nice article, has been almost like 10 years, about what the alpha-synuclein is happening inside the neuron. Usually that's Parkinson's, the Lewy body, or it's happening in oligodendrocytes. It will be more Parkinsonism. But that's in the central nervous system. When we went more to the nerves, the cervical and the thigh on the ankle will be different. Can differentiate between Parkinson's versus multisystem atrophy. For the pure autonomic dysfunction, you will see in the biopsy how sensitive, how specific. When we talk about sensitivity and specificity means how many positives we can get with that, how many we can capture with that particular test, or what how good is the test to detect the negatives. So we're going to see about 90% specificity and 100% sensitivity of 90% and specificity of 100%, which is very amazing. So let's look at this at the back again. This is the full video. You guys again for the two physicians and they want to go more in depth. The full video is there, and actually they can tell you exactly how the biopsy can be done. So for multisystem atrophy or MSA, they have like 90% of sensitivity and specificity 86%. Parkinson's disease, again, is very good, 90% versus 69%. And in between, there is another conditions that is not only alpha-synuclein, they can look like Parkinson's, they had to look for another proteins like tau, the PSP, or cortical basal degeneration. So again, it's not only one misfold protein. So sometimes we look MSA versus Parkinson's. That's something, again, in the past we cannot distinguish, or we try to think about because you have multiple systems being affected, or you don't get better with medication, but now with biopsy, you can kind of sort out what's going on there. So let's see what happened here. So look, 100%. We can see 100% use one or the other, right? So this very good. You have 100% of both is very good. I think not many tests can give 100% and 100%. So with the other one in between, for the PSP, you see is less, and again, because there's another biomarkers in between. So look at this. So for the PSP, which is progressive supranuclear palsy, which is one of possible Parkinsonism. This condition is people look like Parkinson's, but they can have very difficult to look up or look down. That's a progressive supranuclear palsy. You see the 42 or 48, and then we have the tau. Tau is another protein that is misfold, and we found as well in Alzheimer's. They could be overlap with these markers. So in this condition, the PSP or cortical basal degeneration, again, there's some more with the tau. You see in Parkinson's, no tau. You see, that's what you see in the patients. And multisystem atrophy, a little overlap. 1 of 18 patients found some tau protein as well. So talking about these misfold proteins, again, going to the clinic in Alzheimer's, we're a little behind in Parkinson's. But the tau as well is used to see the beginning of Alzheimer's or how aggressive is Alzheimer's. But again, it's another misfold protein, and again, it will be overlap with this Parkinsonism. So hopefully in the future, we can tell you we have some therapies against these proteins and try to modify the progression of Parkinson's, PSP, vasodilatation, or multisystem atrophy. So this is where we do the biopsies, and actually in the video they can show you. And this morning with Ben, the resident, will look the scars on this patient that have this, and that's the first one that we have in our practice. It seems that just getting the answer, it takes several weeks. So I'm waiting to see what the answer is. So the C7, you see the more proximal area right here, the C7 area. So we see that. Then the distal thigh and the ankle. So there's 3 places, and that's very important. Again, this is not for everybody, but again, in the future, probably could be the norm. In that way, we can go more specific for the diagnosis. So let's see what happens. So you would take a little piece, like a little bunch of the skin, and then hopefully in the center we have the light. We have the diagnosis of what is the condition is. So this is with this small piece of skin, we can make diagnosis of Parkinson's disease in about 92%. For multisystem atrophy, 98%. For Lewy body dementia, so Lewy body dementia, remember, dementia of Lewy body, 96% is very good. So we're looking at that scan now. We're looking for the biopsy. And for peripheral autonomic dysfunction, it's like almost 100%, which is very good. I don't think too many studies can do. versus you see control, normal controls, only 3% presented with that. So this is what we call false positive, or people call aging process or something like that, or they don't have any manifestation of dopamine deficiency. So you see the difference, 3% versus almost 100% is very good testing. And we're very happy to say we offer that. Sorry. I want to show you that. Yeah, so I want, and that's a good question. Give me just 5 minutes. I want to answer that question. So the deposition of the alpha-synuclein in the studies and then with the research is different when it's more proximal versus distal. Give me just a couple of slides for that to answer that question. So the biopsy again is correlates very well the results with what we do clinically with the Unified Parkinson's Disease Rating Scale with a score, as well with the stage in Parkinson's, the Hone-Jar score, with the MoCA for the cognition, the PDQ is quality of life in Parkinson's, and as well talking for the MSA, the orthostatic or autonomic dysfunction. Okay, so let's look about again what this is the statistic, how significant is for Parkinson's, MSA, and peripheral autonomic dysfunction or failure. This is actually looking for the statistic is very good. So this is your answer here. So going to the C7, more proximal, usually in the type, C7 is positive for Parkinson's, for dementia Lewy body, and autonomic dysfunction. MSA, so more proximal here and here, more likely Parkinson's. The MSA is more distal. So we usually tied ankle more than C7. So the tied, the more distal is more, the more distal you are, more peripheral nervous system. So that's the autonomic dysfunction with people who are orthostatic. Parkinson's disease, Lewy body dementia, that is more central. So C7 more than tied and less in the ankle. And you see in MSA is more leg, that and the C7. That's the found. That's the important. That's the you find something is the alpha-synuclein is more in the leg, more just broadly in the leg, more than the C7. We're looking more for MSA. So that's the beauty of this. So you see the difference. And thank you for your question, but you get 2 slides too soon, but it's there. So that's the answer, and that's our knowledge we're getting from this, and that's why again it was when we don't know this very nicely, like 2, 3 years ago. So you do biopsy, so what? They tell us because we don't know very well, and we were thinking about the previous articles about multisystem atrophy. We look at oligodendrocytes. So we don't know, but now we know more in the peripheral nervous system, on the skin, how the distribution of the alpha-synuclein is different with different alpha-synuclein. So you know you have poor autonomic dysfunction, or MSA, is affecting the more the peripheral nervous system and producing orthostatic hypotension, or lack of sweating, more the constipation, more than the tremor, more than decreased facial expression, less than the hypophonia, that the other features in Parkinson's. So I think this is very good that we're getting there. And then I want to connect this with another things, biomarkers like alpha-synuclein, but we have as well some electronic. This morning I tell my residents we can do the bradykinesia, but that's my eyes. He said, no, it's fine. He said, no, it could be not. But now we have devices to measure that. So the iPhone, the iWatch is going to, okay, no, he's a little slow. He has tremors. They say the people have an application for the sleep. That could be for when he's getting off, So this is a lot improvement with deep brain stimulation. We could have the artificial intelligence. And this morning I was speak with Ben. He said, Ben, you think the artificial intelligence is going to replace us? Probably not, or probably yes, we don't know. Just the craziness of all this intelligence, so we know what the computer is taking over us, so we'll see. Okay. So this is proteins we probably want to help us with the clinical manifestation. So something is atypical, we go to the biomarkers. The same we talk about biomarkers, we talk about in Alzheimer's, probably could be a little easier in the sense now we have 2 biomarkers, the tau and the beta amyloid. So we can answer yes or no with Alzheimer's with a test. We have the ApoE, the ATN, and now we have the beta amyloid PET scan. This is simpler. It's a yes or no question. Here, the alpha-synuclein is 0, 1. It's a spectrum, so we need a little more areas to test to see is one or the other. So this is the proteins. These are different proteins we're talking about, the biomarkers. So in Parkinson's, we're thinking, or the alpha-synucleopathies, looking Parkinson's, Lewy body dementia, but as well we have the tau. The tau is in between, as well as present in people with Alzheimer's. We have the TDP-43, the neurofilaments, and the tau 217. So it's not only one tau, there are different taus. So this is misfold proteins producing neurodegenerative disease. So the more we learn different markers, we can make a differentiation between things that are very similar. I always said this, you see this, we have it a little more clear. This is actually here in Sarasota. Somebody taking this picture in Siesta Key. That's not my picture. I wish I did that picture, but in any case, we live it here in Paradise. So we have a little more clear this the horizon of the things right now. And again, it's not white and black. Sometimes it's pink, right? So that's the thing about this. It's not, our diagnosis is not straight. Black and white would be pink, would be gray, and sometimes would be something atypical. So that's why we try to get some help with this. Okay, so let's go to a different topic. And again, we go back to the biomarkers with electronic in the end. So another thing we have to look about tremor, essential tremor. So all we have to talk something different is not only Parkinson's. Many people have been misdiagnosed with Parkinson's where they have essential tremor or vice versa. Or sometimes people can have both, right? So always we recommend to have some devices. So we look the movement. This is not tremor, this is movement. So this is rhythmic tremor or movement. So we have several devices. Even you see here this device, this device here, if people even having tremors with this thing right here, people even tremor like this, then it's not moving. So this is for essential tremor, or even people having both conditions to improve quality of life. So the study showed how we can improve quality of life with a deeper bowl, or we have a heavy utensils or devices like this, or even like a wrist that has some other things. Sometimes getting too sophisticated. And actually there is a device that's supposed to improve the essential tremor. The brand is Scala Trio. I found that very disappointed. I haven't used it too much, but it's there and it's approved by the FDA. Okay, let's get to more of this horizon that we have here. And then this is, let's go back to the old, the amantadine. Again, I've been using in the previous pandemia for, it's actually a flu medication, but we found very helpful in dyskinesias. But I want to talk in particular in the journal, take it again for the amantadine. Some people can get not just the dyskinesia, we know they pick the dose, or we're not dyskinesias, but very bad blepharospasms. They closing at the peak of the dose, they close the eyes very badly. Let me go to this, like that. Right there, you see that what happens, and after the amantadine, how they get better. Let me go back. So there's something that's striking after getting the dose or peak dose of the dopamine. So that dyskinesia usually can happen in the plateau, or can happen 1 hour after taking the medication, or could be weird enough. So we'll see when the plateau levodopa, the low levodopa can produce some choreiform movements, that the dyskinesia. Sometimes that dopamine dyskinesias can look very similar to tardive dyskinesia. We have again with Ben this week, somebody have a very bad tardive dyskinesia, and we found a very interesting case of having abnormalities in the basal ganglia. We don't know exactly the etiology of that, but we treat it with medication for tardive dyskinesia. So again, not everything that looks like Parkinson's, drug-induced Parkinsonism, or something that affects the basal ganglia. And after having that, we started the symptom, but again, sometimes it could be, we don't know. We just started finding out why this patient had this. And we wondering with this particular patient, Ben, that we have somebody with this GLP-1 medication for decreasing weight. Some, I don't know, they can produce significant hypoglycemia, but the history didn't tell us that that was the case. But in any case, we see damage to the basic ganglia, and the person presented like tardive dyskinesia, and she's getting the medication for that, and so far it's getting better. But she's got a medication for her today. So what's going on? What's your diagnosis? Why you have this? So the answer is said, I don't know. We're looking. So the amantadine, again, is a very old medication, and we're using for dyskinesia. So the dyskinesias of the eyes, so dyskinesias of the eyelids. So if something is not common, sometimes you see people with blepharospasm or see dystonias of the neck, but this is something that is not very common. I have one patient, to be honest, only of everybody seeing having this, and having, he has DVS, but had this significant dyskinesia. So learning all this, I want to think and tell him probably had to use amantadine. I was thinking about bottles, but I had to look at this relationship with the peak of the dose of dopamine. So again, that's a strike to me, find out this kind of stuff sometimes, but we learn, and that's why they're up to date with the journal. We see what's going there. So we learn every day, cases, right? Doesn't tell me rest. The best way is you have an interesting case, I send an article, and then you're learning from that, and you don't forget. It's, I remember that patient have a TD, or I remember this patient had Parkinson's. And beside that, I was teaching to Ben, and then he has a lecture with the hormone disorder, Dr. Sutherland, so he's very well known, and he's a professor in Sarasota Memorial. And we work together. There's no more competition. We have patients. We have a lot of patients, so we work together. We meet all the time, and now we're into Dr. Hauser. Dr. Hauser is another one, and again, this is not commercial, but Dr. Hauser is an excellent researcher, and is somebody interested to do any research in Parkinson's, is a person to talk, and hopefully have the communication. So with Dr. Hauser, we talk. He was the one that do the corrections, right? And he was participating as well in the pump for apomorphine, and now there's a pump as well for levodopa. So we're very pleased to welcome him next month. Okay, we're looking about this blepharospasms for somebody, again, for physician they're interested. There's the full video for this, about this, what happened with this patient, and after having the amantadine, how he can open. You can see before the amantadine and after the amantadine, how amazing he got better. Sometimes the answer is not getting more dopamine. Actually, dopamine sometimes can make a situation worse. That's why our philosophy is try to start dopamine later on time in Parkinson's, try to hold it for a long time. And the earlier you take dopamine, the longer you take it, or the higher amount you take it, you can have something like very severe motor fluctuation and dyskinesis. Okay, remember, we have this as Venice, so again, that's it's a part of the world you're waiting for you. We have Venice, Florida, but it's Venice, Italy. Okay, so there is another medication that we talked in the previous talks about, opicapone, which now is used as well in the pumps, and the gel pump from carbidopa. And in the combination seems to be working better. But again, before the Crexon, before the Rytary, we use this duodopa, but now they are doing the combination with that, and see this is working better. But again, we try to avoid to be too invasive. We have our pumps. We have the one with apomorphine. Apomorphine is, it sounds like a narcotic, but it's not a narcotic. It's a dopamine agonist. The configuration looks like morphine, but it's something that people with getting off. Back in my fellowship, I remember we do apoquine that was an injectable. The problem was an issue with getting a nausea, and then we used something back in the day was called Tigan. Somebody had to answer the phone. That's okay. Okay. That's okay. Mine is going to ring in 1 second, no worries. So the apomorphine or apoquine was used, or is still using, as a rescue therapy for people having a very bad freezing episode, or off time, suddenly get it off. Sometimes people getting that episode of getting off, sometimes confused like a seizure or passing out. It's be so bad they here want to move, so they can do the apomorphine, and now they have a pump. So the pump is something they can use it and give more on time. We have a lecture with Dr. Hauser, and plus he's going to talk about next month about this. So he will to be continued as Netflix, the series 2 to be continued. So conclusion, so this OPC, in addition to the gel, it seems to be very well tolerated and seems to be improving the motor fluctuations. So they said they need more research about doing this. This is again in Sarasota. Somebody in our community in Lego Ranch, they took the picture. Again, this is not picture of mine. I look in the group of Facebook, and beautiful place. So again, every time we say that we have this problem, that problem, you open your eyes, you see you are in paradise. We are in paradise. Thank you for having us. Okay, go to a different topic in this journal. So some technology is available. So you wondering always if I have people bringing to a smartphone or having another technologies to look for your rigidity or your off time or your bradykinesia or your voice. So we'll see how, this in conjunction that this is like technology biomarkers. There's the way you can, because something now I say for experience said with Ben, I said, I think place 1. He says 0. No, because that's my experience. But it's between two clinicians, but you're looking at with a electronic device, they will not fool you. They tell you yes or not, it's bad. They go on the hertz, the movement, and so on. So that's we support our knowledge and experience. You know, I always said that the experience is the knowledge that you acquire when you don't need it anymore. Now you have the experience. So when Ben had the experience, that's easy. That's easy. Now, at the end of this week, Ben said, "No, I experienced Parkinson's." So he said, "Dr. Gonzalez, you can go to rest, and you can then rest in the afternoon." I said, "Thank you, Ben. You can do that." He got to night flow tonight, so you go to rest tomorrow. So it's fine. Thank you, Ben. Thank you for your job as excellent job this week. Okay, so look at this again. This is the comment in Facebook. This is the moon, and this is very nice. It looks like in the moon you had like something like a river coming from the moon. So it's amazing how this is the flow. And this is electricity. We will do brain stimulation, activate the rest of the things. Okay. So this is the technology. So this is the studies that show in the journal about different things, about different devices to use in Parkinson's disease. So this is the old studies I just show you. Of course, I'm not going to each one of those, and there is more. How accurate with them? Some devices, but let me tell you about this. So basically, they're looking how people have been using different technologies to like smartphone applications and different platforms to look for early diagnosis or how you're doing with the Parkinson's. Actually, back in the day, I remember there's an application to look for the tremor and Parkinson's. Back in the day, it had been like 10 years, but now we have more sophisticated. So there is a lot of research, but there will be another article to talk a little more about this. So let's go to the next one. So this is the digital innovation. So this is the boom now, talking about how the technology or artificial intelligence can help us in the clinical setting. Okay, so what are the digital tools we have? So we have, for example, for the speech. So we talk about a hypophonia, and they said, I always ask, you think your speech, my favorite relation, you think your speech is a little decreased? I said, no, it's fine. I have the impression probably yes, and sometimes it's very clear. But there is some tools that now they can tell you, yes, you have hypophonia. Or do you just follow, they say, you probably in the future, you said, you're speaking too fast, you get the vibration, or you have to speak up, right? So that's the beauty of that. But in the same process, you say, okay, how much this technology is taking over my job, or how it's going to help me. So they have the digital speech biomarkers, and they tell you about the volume, and then we have been talking about people having difficulty with the stuttering, hypophonia, difficulty swallowing. All these non-motor symptoms and Parkinson's can be helped with this kind of stuff. So let's look at this, the digital biomarkers. So in the center, you said the artificial intelligence. So that is helping to place all together. So we have the electronic biomarkers, we have the biological biomarkers, the clinical biomarkers, and then the labs. We just talked today about the biopsy, so we can go there. Or we can do the DAT scan, the imaging. So you see that somebody getting a scanner, have a nuclear medicine. And many people get very scared about because it's nuclear medicine. No, this is going to, it's radiation. I want to do that. But sometimes it's not black and white. Again, some people get with a little bit of tremor, but mainly it's essential tremor. Sometimes we figure out you have the beginning of Parkinson's. So it's better to make the diagnosis, or we can do before the decrease in sense of smell. If you get a appendectomy, we can test that for alpha-synuclein. You have decrease in sense of smell on your family. They can start doing some studies in the beginning to see if possible you want to develop Parkinson's or Parkinsonism. So you see, actually, you have your iPhone and the tissue you hand that you have that, and with the application will tell you you start having some issues or complications. So let's talk about some of those. For example, akinesia. Akinesia means not able to move, or bradykinesia. Brady means slow. Bradykinesis, moving. Bradynea, slow breathing. Bradycekia, very slow thinking. So they're resistant to quantify your movement, the speed, or you have difficulty with the movement. For example, repetitive tasks and so on. So this is, I can go for every single symptom of Parkinson that sometimes it's difficult to address, but actually we can quantify in the future exactly each of one. Facial expression. Like you say, oh, you come Thursday and they say, oh, you think you have little decreased facial expression? No, but I have Best palsy. But I think, no, but it's sad. No, I think you have decreased facial. No, this I always like that. I say, always like that doesn't mean it's okay. It's like I said, but you have constipation. No, I'll be in constipation, so it's normal for me. They said, probably not. That probably is indication that you have dopamine deficiency, lack of sense of smell. No, this is for you. This is myself. This is part of me. No, that could be part of you alpha synuclein. Start from the nose. That remember, the decrease of sense of smell could be part of the beginning of Parkinson's. And you know what happened with COVID, right? COVID decrease in sense of smell. So many people, so we've been talking now that we have some cases reported with Parkinson's associated with COVID. So some people say the history. Before the COVID, no problem with my sense of smell was bad. And then later on check on with some tremors, and then we found the probably is the COVID. So remember, in the last pandemic, we talked about that. The encephalitis bad economo, people have the encephalitis lethargica, and then people have, some of them, they have Parkinson's. Gait, gait and posture. Many people say, no, I'm old. I always like that, it's my back. So you know, there's two posture could be associated with Parkinson's. And then there's a point to say, yes, what part is your Parkinson's, or what part is your age, or what part is your back problem? So there's some thing that, because this is symptom, again, it's my clinical view, but now the technology will tell you, yes, no, it's not Parkinson. It's not your gait. It's not because you're getting old. It's because you have normal pressure hydrocephalus, or it's because you have Parkinson's. So there's a way to quantify that. So there is a lot of sensors. So you have you know, the people have some rings with sensors. You have the smart watch. They can tell you blood pressure. Some people can not have atrial fibrillation, but as well, it's possible in the future say, oh, you're getting off. You had the time for you to take your medication, or is the time for you to adjust your dose, or is it time to take an extra Crexon, or is it time to take your Imbrilla? So the sensor will tell you, not only for the sleep. Many people do for the sleep, for blood pressure, but now with the Parkinson's, they can tell you about how you're doing your speech. And I always said to the wife, remind him, you have to tell him he's speaking too soft. He remember, and they gave me the look. He said, it's okay, you can give me the look, but you can be mad with me, but you can tell your wife, she will remind you to speak louder. And it's fine, you gave me the look, but you gave me a better voice, next time will be awesome. So they will tell you, you are not speaking fast, or you're not speaking loud, or you're not walking enough, or you know swing your arm. So they can censor. So you have your iPhone there and say, okay, you swing one arm better than the other, so they can remind you. So we can take the advantage, not the technology take it over us. We probably have to help it get a little deal with the technology to work together. So smartphones, smartwatches, all this is probably help, and this is there, it's here for many things. So why not to use it as well for this whenever people have freezing episodes, getting off. In the past, we rely more in the diaries to say, okay, when is you're on, when you're off. This is going there, and this happening with deep brain stimulation. The deep brain stimulation is telling now a feedback when the patient is back, and they get by itself the feedback. And we talk about Medtronic usually have this new, and we're very happy to get that. And in the future will be more and more and more coming for the artificial intelligence again in our advantage. And in the past, we take like 2 hours to have the programming for first time with somebody DVS. Now we by hand know what is the best, because that the electricity we look for the beta activity and know what the electrode to hit. So this is getting better and better, but again, a little scary at the same time. So beyond the wearables, we have wireless monitoring, like infrared. Like you walk in and the infrared, oh, look at you. You say it's not good. Camera, something is like, again, like in the speed cameras in the traffic, you will now is the traffic and you home, and you see something that sensor is, okay, you're not walking fine. I said, wrong. You have to walk faster. Or you see the alarm, you have to do it, something like that. You see, something like that. Thank you for the demonstration. Okay, so something that can place in the house with the gate, the speed. Somebody have the alarm then. Good for the demonstration. Okay. So those monitors can actually monitor continuously at home or in nursing homes, physical therapy. The physical therapists can as well get all these devices to assess how people are doing and how they progress or improve. The rigidity, sometimes very difficult to assess, and then we said, okay, the co-willing. So we always teach our students or in the clinic how the co-willing, the knife slab, rigidity, co-willing, how they look like a German clock. You have stiffness, release, and sometimes very difficult to assess that, but with the EMG, we can look about how much is the tone of the muscles, but there is another sensor that can look for that. So again, more and more technology to replace our clinical judgment. So what's the future? Do you think the artificial intelligence is going to take after us, is going to work with us? So we're looking at is going to be something to look for in our side, but again, could be an issue if we don't control this kind of technology. Okay, so we talking about the different proteins, the biopsies, we have the electronic biomarkers. So all together is helping us to assess better in our patient. Before we thinking, we guessing, but now that's why we're into more to biomarkers to get. And somebody said, so why I had to do the biopsy list this morning? So what's the reason to do that? Because it's different. I diagnose you with multisystem atrophy versus I diagnose you with pure motor dysfunction. Like somebody have orthostatic hypotension versus somebody have orthostatic hypotension, but decrease of sweating, plus issue with balance. Like, so that's the prognosis much different. You have pure autonomic dysfunction, the issue is just the blood pressure going up and down or down, versus the multisystem atrophy is more devastating disease. The prognosis usually people just progress faster, so it's much different prognostication. So we have a little more. It seems to be a little cloudy, but sometimes had the light there. So it's again we had to take advantage of our paradise, but sometimes the storm come my way, right? So you have to be prepared. So finally, we want to have this, you see like an eye in the end. The eyes in Parkinson's, I have somebody having a complaint of his eyelids today and having some secretion. So there is a very nice, very important glands that produce like a small light, like a little oil to lubricate the eyelashes. And sometimes just getting analysis for that, we can say, okay, this patient start getting some Parkinson's. People said before as well, you look in the back of the eye, but this is a very comprehensive study looking about the function of these glands and the corneal sensitivity and tears, the production of tears or not in somebody that can the beginning of Parkinson's. Okay, so we get into the end now. It's like, so again, I still remember this picture. I love it. I want to place it in framing. So in Venice, getting a little close up for that. And probably went back to be romantic in Venice or somewhere else. Remember, you have to live every day. And thank you so much. Okay, so I open for questions now. Thank you, sir. It must be 100% of the people in the world that tired. Yeah, so the question is, he said the Parkinson's is to be exploring, and yes, saying 100%, that means 100% is too much to say that. But yes, Parkinson, unfortunately, with the pollution, the pesticides, toxins that we're exposed, definitely. And now you said we were close to all the, and I was talking with Ben and Dr. Sonley mentioned it again. Here in Florida, we have a lot of golf, right? And we talk about this and articles about that. Here in Florida, we have exposed to pesticides, to all of these orange. We here in Florida as well, we have for the environment. Actually, the air is very good, but in some areas in Florida, there are more industries, so the pollution, people in the military as well more exposed to Agent Orange. So all these oxidants, and we have some genes, and we can discover more biomarkers. So play some genetics, so we sooner than later we can get the biopsy. Somebody have familiar Parkinson's to look either it's the genes or they have the proteins and see what's going on. But you're right, the Parkinson's is getting significantly. That's why with Dr. Solon we have a lot of work to do and try to help everybody here, but we need more people to treat Parkinson's. Yes, sir. So thank you for your question. So his question about the research and just is only motion. So I just explained to you today this Parkinson's, the tremor is only the tip of the iceberg. I just placed to you and explain it's not only alpha-synuclein. I just show you today the spectrum, all the no alpha-synucleinopathies, but as well some tau. We talk about some in between. So there is a lot of research, and that's why I want to bring Dr. Hauser. He's looking at all research, and again, is when we talk about Parkinson, most of the time we talk about the tremor, but we forget about cognition. We forget about swallowing. We forget about neuroprotection. But there is a lot of research. We tried the same we're doing, or trying to fix, or trying to get to root the problem with Parkinson's, and that has been a little more one step forward in Alzheimer's. We're doing the same in Parkinson's. Actually, in the New England Journal of Medicine, they're looking at already studies with monoclonal antibodies about, again, the alpha-synuclein. But you can look with all we talk today, it's not that simple. It's not only one protein. Sometimes it's several proteins. And try to target one. It's not like one shoe feeding all, one shoe, yes, feeding all the feed. So it's very difficult. And especially somebody have a gout or a bone, it's different, right? So it's not that simple, and it's very complex. Unfortunately, with this neurodegenerative disease, because they are chronic, it's very difficult to get one solution. And again, we said the Parkinson's or Parkinson, the spectrum is very broad. So it's more difficult to try to only one cure for everything. So it's more difficult. So it's, as you see today, we see all the spectrum, the biopsy or the biomarkers telling us it's very complex. Anybody else?
I know it's something I probably understand, but you use and others use the term Parkinsonism.
Mhm. So the question for the people on the Zoom is, she's asking me that we use sometimes the term of Parkinsonism. So Parkinsonism is not typical Parkinson's. We're talking about something is going away from the Parkinson's. Not everything you look is Parkinson's. Sometimes look like Parkinson's. And the difference is, I always give this example. You look at me, you say, Dr. Gonzalez, you are Mexican. I say, no, I'm not Mexican. Mexicanish, no, that doesn't look a Colombian. So nothing, everything that look like is not Parkinson's. So look at that, it's an spectrum, it's not black and white. So the white, they say here in this spectrum, you have Parkinson's, where the alpha-synuclein is inside neuron. You give it the dopamine, and people do great. In that spectrum, on the other hand, we have the Parkinsonism. That could be something like multisystem atrophy, could be the autoimmune, the autonomic dysfunction. MSA, PSP, cortical degeneration, all this spectrum in that umbrella of Parkinsonism. In general Parkinsonism, that means that most likely atypical, most likely the dopamine will not work, most likely, and this is the difference. In the New England Journal of Medicine, for Ben, I will send it to you, you find the pathophysiology in the Parkinsonism is different. So the alpha-synuclein is not inside the neuron, it's in the glia. So the alpha-synuclein is going to the cells. The alpha-synuclein is the cell that support the neuron. So the neuron is full of dopamine. So it's like you have your tank full and you try to place more gas, overflow. It's not going to work. It's not going to help. The problem is not the gas. The problem is how you process the gas, right? So it's like how you support the neuron. So that's the Parkinsonism. So it's not a typical presentation of tremors. Usually you say, no, I take dopamine, I increase my medication, it's not helping, actually have side effects. That's more the Parkinsonism. So we have reflux. The tremor, it doesn't happen in one hand at the time, but happen in both hands. You have the flavor, the issue is not the tremor, so the motor part is more the cognition first, or you have only the issue more the blood pressure, and actually the medication is not helping, actually make it worse. So we're thinking more reflex for Parkinsonism. And that's why we distinguish between Parkinsonism, have this reflex, please come to the dopamine challenge. People say, no, I think the medication is helping. And they're giving more and more dopamine, and what happened is the more they give me dopamine, I get worse or have side effects. So it's a red flag for me. I think, oh, probably you have more Parkinsonism. And then the dopamine challenge started giving the medication. I give only 1/4 of the pill at the time, and it's not getting better. Actually, blood pressure go bad. You feel not good, not great. And then he said, 2 hours or at the end of the visit, said, how are you feeling? No, I'm not feeling great. I usually actually worse. And many people come with very high amount of dopamine, and when I actually taper down, they actually feel better because it's no lack of dopamine. Actually, it's the way you process it. More dopamine is not the make it better, actually make it worse. It's like overflowing. That's the Parkinsonism. So I Colombian, no Cuban, no Mexican. Anybody else? Any other questions? Yes. So the question is if all doctors do the 3 place for the skin biopsy. So this is the protocol that's doing here in the States, and not many places doing it. Finally, we get it here. So it's not many doctors. In the past, we sent it to Tampa, but now I have my colleague, Dr. Rota, he does skin biopsy, so he's doing it. So probably have like 3 already in our practice, but not many times. And we got this now. And where I feel now, it seems to be the process of getting the results, it takes weeks. So for the last one, we have like 3 or 4 weeks and still don't have the result because they had to go in a specific place. I don't know, it's in California, also with this. So they had to go there. So yes, it's at 3 places, and that's the protocol because that's the main thing. You're getting more proximal, we're getting here more Parkinson's, so Lewy body versus MSA more distal. So that's to be in the 3 places. Yes. So the question is, we're using the diagnose, or is because patient not responding for carbiopallopa? So in the future, could be probably the standard of care, but not everybody needs the biopsy because it's very clear the patient already getting well with carbiopallopa, and it's very clear this is a typical Parkinson. We don't need to do that invasive. But if somebody's not getting better, and the whole purpose of doing the lecture today about the biopsy, because not everything is multisystem atrophy, not everything is just the blood pressure. So I have to look in that spectrum between the black and white, what is the problem? So that can help us. And the future looking for other proteins, I said, no, you don't have alpha-synucleinopathy mainly, you have more the tau, or you have more PSP, we have corticobasal degeneration. So it's important for us, the clinical, but now we have this help to distinguish, and really if the medication is not working, it is one of Parkinsonism. We know from the beginning that it's not working, then we go there, and if the medication is not working, there's no point to give it to you. So basically the medication is producing more harm, and it's no point to give it to you, producing side effects. So it's for both, to make the diagnosis and look the value to do carbiopallopa. But again, this is not black and white. You see some people have some MSA and give dopamine, making a little better. Or sometimes I give it a little bit of recycling or give you a little bit of primary impact. So but the most part, usually you're more to the close to the Parkinson, the less improvement with dopamine. So it's for both. Pleasure.
I want to get a definition of that one drug called amantadine. What was that?
So he wants to know about the definition of the drug amantadine. So amantadine is a very old medication. So let me give you the story. I usually use a very simple examples, but back in 18 in 1918 was the first pandemia, and it was the Spanish flu. And that Spanish flu, people giving some medication for the flu. So that medication it was discovered as amantadine. It's like today we have another medication for the flu. So basically, people having not only the flu, but having Parkinson's get better from the flu and getting better with Parkinson's. So it's, oh, something is here. And then the amantadine is one of the best medications we have now for, especially for dyskinesias. We found amantadine as well very good for now for the blepharospasm. We learned from this article, but amantadine as well and long-acting is called Gocovri, and that medication give you more on time in Parkinson's. So amantadine is actually originally a flu drug, but works somehow in Parkinson's disease and different pathway in the MDA receptors and help us to give you more on time. But especially in the beginning, we use it for complication Parkinson's like dyskinesias. But now we have the dyskinesias, but as well we found the blepharospasm. But in some people, we're having dystonia, meaning crawling the toes or having difficulty walking. I have been studying for improved gait in Parkinson's. So amantadine is working for that. One big side effect with amantadine would be hallucination. So we have to be very careful with somebody 80 years or 90 years because that can produce hallucinations. But in low dose could be good. Or if having hallucinations, we can do the long acting. But it's a very good drug now. And I have more than 100 years old and it's still working and kicking. Very good. Sorry, repeat that again. Repeat the question again.
Stay away from that.
Iron. Yeah, so you may need iron, the metal iron to be so. I don't know about so the question is about stay away from iron. So I don't know the iron is producing Parkinson. We're talking about oxidation. You know, iron can be oxidated, but iron you have the normal iron is very important. Is the element that carries the oxygen. So iron is produced the hem in the red blood cell. So you don't need it, don't take it, but you look for your levels. But iron is very well known to have a very abnormal iron in Parkinson's or on all these. At least you can see decrease in the substantia nigra or the metabolism. Many people having Parkinson's or having Rayleigh syndrome, at least there is abnormal iron metabolism in Parkinson's. So you see the substantia nigra in the midbrain that's where they have the iron. So iron is very important. And at least we know the metabolism of iron is abnormal in Parkinson's. And one precedent or something that can happen before Parkinson's, and many people with Parkinson's as well have Rayleigh syndrome. And Rayleigh syndrome is as well, at least if the iron is not low, the metabolism, you have the profile is abnormal. And we use in pregnant women, they have decreasing or anemia, people losing blood, or having any hematologic condition with the iron metabolism is not fine, they can develop some Rayleigh syndrome. But again, it's very well known in Parkinson's have abnormal metabolism of the iron. And not only that, we don't know what the chicken or the egg, but the alpha-synuclein can affect those pigmented. You see black is black because it's iron, a lot of disposition, iron, the substantia nigra. So the alpha-synuclein affecting those cells in the midbrain is when you start having the tremors. So iron is a very important element. You have a question, you have to have the iron profile, and you will see it is not high, it is not low, you don't need it. But if somebody has Rayleigh syndrome, iron has a very good is one of the first treatment for red leg syndrome, especially in people with Parkinson's or people with anemia. So again, you don't need it. Your iron is fine, don't take it. But it's a normal metabolism. You have very bad red leg syndrome. If there's an iron deficiency, it's a treatment for red leg syndrome. So her question is about, is a good pleasure, a good idea to monitor the blood pressure? The answer is yes. So remember, not only because all this dopamine deficiency or anomalies can produce autonomic dysfunction. Some people can, the blood pressure go down, but as well the medication that give you, and we just talked the carbidopa can make your blood pressure down, and that's usually the case. And now we told my residents that they know dopamine. We using somebody had the issue with the heart. A low dose dopamine is chronotropic and inotropic, so actually make the blood pressure higher. A very micro dose, meaning low dose. But the higher dose you use in dopamine is the opposite. Actually can make the blood pressure low. So that can produce hypertension. But some people with autonomic dysfunction of this Parkinsonism, usually the medication is not working, but actually can make the blood pressure low. And some people with Parkinson or Parkinsonism, autonomic dysfunction, they can have orthostatic hypotension. So that means lying, sitting, and standing blood pressure drops. So it's very important to monitor, especially if you're lightheaded, which is a very common complaint in people with Parkinson's, especially could be from the beginning with a Parkinson's plus or Child-Drager syndrome or Parkinson's plus hypotension, or it's very early in autonomic dysfunction. In the pure autonomic dysfunction, we have some patients have only that. I remember back in my beginning here in Sarasota, somebody have orthostatic hypotension, feeling dizzy. So we found the blood pressure was dropping. And I ordered a DAT scan, and they look at me like I have 3 heads. And then we discovered the DAT scan was positive. And you see the difference. She was having only that problem and still having. But now, after 10 or 15 years, she developed some flavor of Parkinson's. She has some tremors now, some cold willing, and finally has some decreased facial expression. That's the Parkinsonism. So you the difference. And the true Parkinson, usually decreased facial expression comes first, the tremor comes, then really, and finally, and then people start developing dizziness, orthostatic hypotension can happen. So you see the spectrum. So you have with Parkinson's versus that Parkinsonism, and orthostatic hypotension, autonomic dysfunction. Okay, anybody else? Yes, sir.
Yeah, you recommend that they have, talking to the doctor, they have the ER at the end, or it doesn't make any difference?
Okay, so the question is about what medication, I suppose you're talking about the carbidopa, is it standard or see. So we have a conversation about this, probably, I don't know, you attend to this lecture, but we have been talking, and as the example, the carbidopa, and Monu, you want to be tired of this example, but the carbidopa is like an iPhone 1. So you have an iPhone, the software is up there, you can use the iPhone. That's the immediate release plane, right? Then we have the CR, Cinemet CR, people using, but really the absorption is very erratic. Down, because all these fluctuations, they try to get a real extended release. So that's the iPhone 10. That's the right RE. Right RE is really an extended release. The already extended release CRs, they don't work very nicely. They don't work. They work somehow at night. So then after the right RE, we don't have the absorption that the iPhone 16 is the Crexont. Many of you have been in Crexont and know how I love that medication. Really does an extended release. So this is technology, it's again like an iPhone 1, but it's an iPhone 10 with more technology, more cameras, more technology. It's a polymer that goes in your stomach, and they have immediate release and extended release. It's the combination. And that really is going to deliver, it's a delivery system. So it's more sustained. Instead of going like this, then you go a ride like this. It's like you go a very bad roller coaster in Orlando versus have a nice one. And, oh, it was a good ride. It was a little bit bumps in the road, but it was okay. So what we try to get is try to mimic the delivery of dopamine. Somebody has no Parkinson's, the pulse dopamine is delivered constant, and we have no problem. But when you have the problem with no delivery or producing your dopamine, then you have these up and downs. and then we have the motor fluctuations. And that's the problem when you use too much dopamine or for a very long time. The longer you use it, the younger you start, or the higher the amount, the more complications. So initially dopamine start working for 3 hours, then the window start going 2 hours, 1 hour, some point not working that much. And then you use it more, they have the threshold for dyskinesias, hypotension, hallucinations. So now we try to get longer to avoid giving too many times and getting you system. And we see the correct zone, which is carbidopa, really standard release, is usually the best medication we have now in the market for that. So that's what I recommend. Again, I don't have any economics interest in that medication because I get it very passionate because 7 people in 10 people did very well with that medication. And that's my experience. 3 people that usually don't work. Talking about Parkinsonism, for example, or there is gastroparesis, the medication is really an extended release, very slow, but if you place it in a turtle in a highway, it will be a problem, right? You have gastroparesis, your movements are very slow. You place something is very slow, it will not work. So 3 people in 10 no work, but it works. I tend to use at least for a week. Now they don't give me a sample for 2 months. They give me only 1 week example. And then, so please using this for a week and we'll see. But you have Parkinsonism and the dopamine is not working, correction will not work. The same, you have Parkinsonism and you ask me to deep brain stimulation, that will not work. So deep brain stimulation is indicated for people having the real Parkinson's, no Parkinsonism, and DBS work as good as the dopamine. And I would like to electronic try to deliver or stimulate the area for dopamine. So that answer your question? That answer your question? Oh, good. We'll have it. This is Dr. Gonzalez approved. This guy is giving me, now they'll tell me. We'll finish with you and go with her. Tell me.
That a lot of people are promoting that cardamom is the extract of promote the seed, or not eat.
Okay, so he's telling me about over the counter. You just asking about like the natural dopamine? No. So the thing, that's what, yeah, so all the over the counter or supplements we usually don't recommend. We don't endorse because we don't have evidence for one way to another. So the way we practice medicine now is based in evidence. So you show me an article or a real study of 500 people in this a supplement versus 500 not taking anything, and you show me really it's a big evidence, I will say yes. But any of those supplement people, so carnitine, CoQ10, you name it, there's a lot of things and there's a lot of science behind it. But really, we use it, we don't use it. Why? Because we don't have evidence about that. So that's the answer. We don't endorse anything. It's not have base. And you see, you on internet can read a lot of things. And you have to look where is the source of that. You tell me about the movement disorder journal, or you tell me New England Journal of Medicine. You have a question, you go to the National Library of Medicine, look at Medline research, and you really find a serious article, double-blind study with a good sample, and then we can have a conversation. Otherwise, I cannot give you advice. You can spend your money wherever you want, but I cannot endorse one way to another. Okay, so the question is at what point I recommended that scan. So that scan is something that is a tool. It's not that you have to do it every time. And in not any particular time, it's more like clinical situation. So basically, depends on what we're talking about. You have the clear diagnosis, and with my training and the thing, I think it's very clear for me, I don't advise you to have it. But if you have the Parkinsonism, or it's very mild at the beginning, you see just a little tremor, you come for tremors, it's essential tremor, but I notice you have a little bit there, like people have just a little bit the thumb, or I notice you start decreasing swing, I probably recommend you to have that because I need to have it sooner than later. The DAT scan could be recommended in our clinical settings, depends if you're feeling some Parkinsonism, or there is a question about the diagnosis. So at some point, depends on the situation, we'll do it sooner or later. Sometimes it's not necessary, but sometimes it's indicated for the soonest diagnosis. Because if I have something I don't pay attention, then you come back 3 or 4 years later and say, Dr. Gonzalez, that patient you diagnosed with essential tremor, now have Parkinson's. Look at that tremor. So the front desk tell me you have a new person for Parkinson's. So I missed 2 years of treatment of possible Parkinson's. So no, it's indicated for everybody, but it's the clinical, there is some clinical indications. Where else? Yes, sir. Yes, sir. Okay, so somebody has a question here about exercise. So in the previous lecture as well, I said it's better to do exercise the gym and not doing exercise around in the kitchen, right? So so exercise is the amount that you have to do exercise at the point you don't not want to injure yourself. So ideally, you can do it every day. Some exercise would be good. So the question is, how would you want to feel? So remember, people not doing much exercise can feel it very well because you produce dopamine, and it's when you after you do exercise you feel great because what make you feel great is the dopamine you produce. But again, depends how you do. The minimum at least 20 minutes 3 times per week. And remember, we promote is 3 exercise. The most important is the aerobic exercise, like stationary bike, elliptical, swimming, dancing is an exercise, ping pong exercise, pickleball is an exercise, tennis is a good exercise. The second that we recommend as well is strength. So you have to do some lifts. You're feeling a little weak. You want to fall, you can catch yourself because you have the strength to catch yourself. And the third one is going to be balance. So many people say, but the medication is not working. And you say, why? Because my balance is bad. Medication will not fix your balance. So the only thing we help balance is balance exercises. So you can do Tai Chi, again, ping pong, you can do boxing classes, and that's the 3 exercises. So how much we recommend to go slowly. You don't do much, try to do it slowly. Ideally at least three, minimum 3 times. You can do 5 or every day. Walking is exercise, but you have a stationary bike. I always recommend if people don't do an exercise, you say, I know your Christmas gift. Your Christmas gift will be a stationary bike and place it in close to your living room because here is or it's too cold or it's too warm or it's raining. You always have an excuse to not do exercise. But you have it in your living room, use it. And then you can have the Peloton or wherever you want to use it. That's what's best investment. And people having back pain, recommend bike or something. And sometimes people with Parkinson's, we don't recommend much of the treadmill because the balance and they do it too much, they can have a fall. Aquatherapy, swimming is very nice. Most of us have access to a pool, so it's a good exercise. So again, we are very placed, and you are in the right place. You can come and do the exercise here. We have to be sure you have the ping pong, a good use, and then that would be the answer. The more exercise you can do, but the answer is without injuring yourself. You will feel great. Okay. You give me 1 second. Ladies first, and then we go to you. So she's asking about rigidity and movement. So she commented that the more you do exercises, well, the answer for that. Sometimes as well, they say applies for fatigue. So sometimes you see, I don't feel doing exercise because I feel fatigued. So you can find it with doing exercise because there is no, the worst is the alternative. The same with the rigidity. You say, no, I'm so rigid, I want to do exercise. The less you do the exercise or the less you do it, the worse you become. It's like a snowball. So that you need to try to do it. In the beginning, it's difficult. The more you do it, you get a little more flexible. You have some orientation with the physical therapy or you are personal trainer. And again, the main thing is not injure yourself. But yeah, definitely this is the, yes, sir. Nupro. Yeah. Mm-hmm.
Shot. Is that helpful or hindrance to use the tablet?
Okay, so I think I understand you well. It's about the patch, right? Yeah. So the Nupro patch is rotigotine is a dopamine agonist. It's very well used. So again, it's a synthetic form of dopamine. So in the past, and it's still very good medication. The problem is the representation now. We don't have the way for me. In the past, I had samples and I can tell them. So it's a very good medication. Again, could be very expensive sometimes. It's a patch. Some people have a difficulty getting on. Here you are. Sometimes you're sweating or swimming, you peel it off. So it's a good medication. It's a continuous. It's one like a standard release. Rotigotine is 24 hours. You have to use it or change the place, not place in the same place for at least 14 days. You place in the same. The main fear with that is getting contact dermatitis. So it's very important not to place in the same place for 14 days. But it's a very good medication. And again, it's one of the best medications as well for restless leg syndrome. Sometimes the insurance don't cover it, and it could be very pricey. But it's very good medication. And back in when I was on my fellowship, that was there, and they were recalling because there was an issue with the delivery system was looking like a snowflakes. So for a while, we saw the market, but has been there, and it's good medication. The problem is getting the problem for me usually get approved by insurance, and usually getting the contact dermatitis will be a problem. But it's an excellent medication. It's a dopamine agonist. Any other questions? Okay, so next one is Dr. Hauser.